Coronary venous circulation. Importance of knowing the coronary venous circulation has increased in recent years with use of cardiac resynchronization therapy for heart failure. Left ventricular epicardial pacing in CRT is achieved by pacing a lead in a coronary vein, usually a posterolateral tributary of the coronary sinus. Coronary venous circulation can be visualized by a coronary angiogram levo phase. After filling the coronary arteries, the contrast drains into the coronary venous system, finally opacifying the coronary sinus, which drains into the right atrium. Here is a coronary angiogram levo phase with a line diagram beside it. To get better visualization of the coronary sinus and its tributaries, a balloon occlusion angiography of the coronary sinus is done by cannulating it retrogradely from the right atrium. But that is done only just prior to CRT, as there is a small risk of coronary sinus dissection. The veins visualized in a coronary angiogram levo phase will also depend on the coronary artery in which contrast is injected. Coronary venous circulation has been divided into a greater cardiac venous system, which drains into the coronary sinus, and a smaller cardiac venous system, which drains into cardiac chambers. Smaller cardiac venous system is constituted mainly by the Thebesian veins. Coronary sinus is the largest cardiac vein with multiple tributaries. It is located in the left posterior atrioventricular groove and empties directly into the right atrium through the coronary sinus ostium. Tributaries of the coronary sinus are the great cardiac vein, middle cardiac vein, small cardiac vein, left posterior left ventricular vein, and oblique cardiac vein. Great cardiac vein starts from the apex and drains upwards in the anterior interventricular sulcus. In the initial part, it is also known as anterior interventricular vein. In the anterior interventricular groove, it lies alongside the left anterior descending coronary artery. At the base of the heart, it travels leftwards and curves posteriorly near the left atrial appendage. Posteriorly, it converges with the oblique vein of the left atrium or oblique vein of Marshall and forms the coronary sinus. Oblique vein of Marshall is the residua of the embryonic left superior cardinal vein. Middle cardiac vein also originates at the apex but drains the posterior side of the heart and is situated in the posterior interventricular sulcus and empties into the coronary sinus. It runs along the posterior descending coronary artery but in reverse direction. Small cardiac vein is in the posterior part of the right atrioventricular sulcus. It also drains into the coronary sinus. Valve at the ostium of the coronary sinus is known as Thebesian valve. Valve at the ostium of the posterolateral vein at the junction of the great cardiac vein and coronary sinus is called Vuisson's valve. These valves can cause difficulties during ablation and CRT procedures. Another practical importance of the coronary venous system is that oblique vein of Marshall can give rise to atrial fibrillation. Three reasons described are the myocardial extensions into the structure, node-like remnants within the vein, and the rich autonomic innervation surrounding it. Levo phase of the coronary angiogram showing tributaries of coronary sinus. Levo phase of the angiogram is obtained when you continue the recording till the contrast passes from the arterial tree through the capillaries to the venous system. Alternatively, you may start recording a little late after the coronary injection to the approximate time for the levo phase. But in this situation, there is a chance of missing the initial part of the levo phase. Levo phase angiogram gives an outline of the coronary sinus and its major tributaries, but it will not be enough for an excellent visualization of the venous anatomy for left ventricular lead placement for cardiac resynchronization therapy or CRT. While planning to locate a good vein for CRT, coronary sinus angiography is directly performed by retrograde cannulation of the coronary sinus ostium from the right atrium. Care is needed to avoid dissection of the coronary sinus or its tributaries, which are thin walled structures compared to the coronary arteries. Since the flow in the venous system is against the direction of contrast injection, proximal balloon occlusion is needed for good visualization of the tributaries of the coronary sinus. The tributaries seen here are the middle cardiac vein and the lateral marginal vein. Catheter tip of left Judkins catheter introduced via the transfemoral route is engaging the ostium of the left main coronary artery. Coronary angiogram LEO phase in another case showing the catheter engaged in the left main coronary artery. Artery is not visible as it is the LEO phase. After filling the coronary arteries, the contrast drains into the coronary venous system, finally opacifying the coronary sinus, which drains into the right atrium. The vein seen in the middle of the image is the middle cardiac vein, and that in the left cardiac border the posterolateral vein. A small inconspicuous vein seen behind the coronary sinus label is the small cardiac vein. Distal region of the coronary sinus is joined by the great cardiac vein. Another distal vein is the oblique vein of Marshall or oblique vein of left atrium. Hyperemic venous return angiography has been used to study the coronary venous anatomy. Here the LEO phase recordings are taken after inducing hyperemia with intracoronary nitroglycerin or adenosine. In a study of 200 patients, sufficient anatomic information needed for cardiac resynchronization therapy was obtained in 99.5% patients. There was no significant difference between hyperemic venous return angiography and occlusive retrograde venography in utility. Visibility scores were slightly higher for coronary sinus and lateral vein of the left ventricle with occlusive retrograde venography. But middle cardiac vein and anterior interventricular vein could be visualized better using venous return angiography. There were no complications with venous return angiography. Dissection of great cardiac vein occurred in 3 patients with occlusive venous angiography, but this did not prevent electrode implantation. Here is a journal reference on hyperemic venous return angiography.